All right, we're going to go ahead and get started again. So it is my pleasure to introduce Dr. Nico Grundmann. He's an emergency medicine physician devoted to improving how healthcare systems operate for those who need it most. Dr. Grundmann and his wife founded Ember Health in 2018 as a way to help individuals take control of their lives and contribute to the shaping of a field in line with their values. Join me in welcoming Dr. Grundmann to the stage.
Thank you. We're going to be spending today's time talking about a care process that we put together over the last 7 years, since my wife and I first started this. Not as the way to do things, because there's a lot of other people in this room who can debate that better than I can, but as a way to try this care model, and then we're going to show the outcomes that we measured from that as we were able to provide this care in the last 7 years. So we're first going to talk about that care model. To understand our outcomes, I do need to present a little bit about our practice itself. We've made some decisions that end up changing, we suspect, the clinical care for the patients that we receive. We'll talk about some of what we call the foundational protocols, often talked about as the initiation series for starting care, and the decisions we made about how to provide that, and then the treatment outcomes. And this data is our internal analyses that you're seeing. For full transparency, we have an IRB with MGH, and they're publishing this data, so we're hoping to get this out into the academic journals in the next 6-9 months, so you don't have to believe my analysis. You can hopefully see that when it's cross-verified. So you heard a bit of background. My career started not in clinical medicine. I did a lot of international HIV work in sub-Saharan Africa with ministries of health. I approached everything that became Ember Health with a health systems and policy lens to thinking about this, kind of what works at scale, what works at a population level, and then personally ended up going back into clinical medicine through medical school and as an emergency medicine physician. And that story of how an EM doc gets into this field is probably a familiar one to the folks in this room. When we set up Ember, it already started being narrower than what we were seeing in the field at the time. We chose to start our practice specifically on IV ketamine. That's the only route of administration that we use. And we also chose to focus doing this just for clinical depression, for major depressive disorder and bipolar disorder. And I'll talk more about the whys in a minute. As of this year, we have 5 sites running in New York City, so we've gotten a fair bit of growth. Each of those sites has their own physician and nursing team at them. So there are 6 physicians as part of this at this point, as we've been expanding out. And then we try to do this care within 3 general buckets, which will be kind of the theme of the rest of the presentation. One was a focus on doing this with evidence-based care, knowing that there were some significant limits to the research world in ketamine, particularly back in 2018. And so they had to personalize that care to the people, in addition to just having the data for how to do it. We wanted a patient-centered approach. We believe strongly that the altered state of consciousness is not a side effect. That's an anticipated aspect. It's how you know you're in the right dose range for this being an antidepressant, and that you could actually help harness that experience in a way that was value-aligned for the long-term goals of the patients. And then we do this within a partner-oriented collaboration. That's not lip service. We will not accept a patient in our practice who does not have a licensed mental health professional working with them in conjunction to the care that they receive at our practice. So we only do this as part of a larger care collaboration and larger care plan for folks who come to us. Starting with the evidence-based, again, the reason we made some of the decisions we did were some early surveys. This is a summary from clinicaltrials.gov where you can see that for indications for ketamine, most of the published research has been around major depressive disorder, bipolar disorder. You've heard other speakers reference this already, but when it comes to academic journals, clinical trials, we felt that the volume of data really supported depressive disorders as an indication that we were going to pursue. Factoid that many of you may know, but ketamine is literally the most researched drug in depression in the last 30 years. This is based off number of clinical trials conducted globally. I'll be the first to point out that many of these trials are phase 1 and 2. There are very few phase 3 trials, but nevertheless, it gets across the point that this is a significant body of knowledge that we have for what works, what doesn't work, of course, with a lot of remaining questions about how best to maximize that. The next biggest drug studied was sertraline, just to give you perspective about what we're talking about. This is not ketamine versus other interventional psychiatry treatments. This is ketamine versus any other medication as a medical treatment for clinical depression. again, this audience in particular tends to have a lot of strong opinions on this for very good reasons. Our stance was to pursue a route of administration specific to IV infusions. That was from the data that we had surveyed at the time, which was showing approximate efficacies for MDD to be highest for IV, with a generally quoted 75% number and a lot of variation to that number, which was outperforming what we were seeing for SQ intranasal lozenge. And for the data that is there, a relatively small number of trials that give us confidence even for those low numbers. One of the challenges in this field is when you're talking to patients and they ask, how does this work? You are going to get a lot of different answers. What we have been using in common parlance for folks is what we refer as a 3-part framework, which is an attempt to try to summarize that research that's been done to date. Ketamine has a biologic effect. We know that the passive receipt of this drug, getting this drug to you in the right way, right doses, all of the technical stuff, causes certain individuals to feel a lot better quickly. Call it an emotional reward system reset, call it much more technical terms that I'm going to be able to give credit to here. Point is that there is an aspect of this that is a biologic change for the recipient of the medication. There is also a deeply experiential aspect. Previous lecturer already mentioned that you know you're in the right dose range for the antidepressant effects when the altered state of consciousness is occurring. We also have some published data that that experiential component can make a meaningful difference. It's estimated to be about 10% of the outcome improvements that you see for depression can be attributed to that altered state. That is a highly debated point that I'm not going to go too deep on, but we knew that holding time for that space, ensuring that the experience could be oriented towards the outcomes we were looking for was an important part of setting up a practice here. And then, particularly for the therapists that we work with, for our partner providers, there appears to be a really strong adaptive window, period of time post-treatment during which it's easier to do adaptive learning. Dr. Wilkinson's paper was one of the first that we saw on this, and it seems to have been panned out. So that this becomes the start of a treatment process. This allows patients to engage in adaptive learning and psychotherapeutic techniques, as well as all of the other ways that you could harness neuroplasticity, and that these 3 things were not the same thing in 3 different ways, but were relatively distinct aspects of how treatment helped. When it comes to the patient-centered experience, there were really 2 parts that we wanted to highlight in on. First is patient-centered in the sense of ensuring patient safety. The sub-anesthetic dose, so to speak, of ketamine has a lot of conversation around how safe is it, and the answer, generally speaking, is very safe. The challenge is that it is not perfectly safe. And particularly when you put on my old hat of systems thinking, pretty safe starts to be a very different conversation when your incident rates start to affect tens of thousands, if not millions of people who could access this treatment. This was a good review that showed about 0.1%. Now you'll note that says of individuals. If you dive into the paper, it's actually of sessions. So 0.1% of times that you give ketamine will lead to a medically significant adverse event rate. Whether you agree with the FDA or not, they also put out those guidelines which also change our clinical care landscape, just from a reality of practicing in the United States. You can give a little defense to that statement if you think about the number of people who could be treated with ketamine for their depression. You extrapolate that number of adverse events to the treatment size of who we're talking about, and we would be talking about 40 to 60,000 medical adverse events a year if you were to treat the US with this more commonly. That's not a number you can ignore. And so our stance as a practice was most of the time patients would be fine, but if we're going to do this at scale, we have to set up a treatment environment that allows for those rare events to be handled safely. Part of that then had to balance with the fact that it's not particularly pleasant to receive ketamine in a sterile medical environment. You want to make sure that not only are you addressing the clinical safety for those individuals, but you are also providing psychological support for those folks. Now you notice I use that term carefully. Our team does not provide psychotherapy. None of our clinicians are therapists. We're doctors, we're nurses. We do a lot of training around therapeutic communications for our staff. It's the biggest retraining component for the people who work with us, but we don't try to work outside of that licensure. What we do is the same stuff that doctors and nurses do every day, which is that we support somebody when they have a difficult experience. And roughly 1 out of 10 of our sessions, statistically, are described as uncomfortable by the patients receiving them. We don't intervene 1 out of 10 times. We allow the patient to express when they would like some assistance, but we do remain on one-to-one care for the duration of the time that they're in our office. Saying that differently, for a standard 90-minute appointment with our practice, that patient will have a doctor or a nurse by their side in a one-to-one basis for the duration of the time that they are with us. They are not left with different patient-to-nurse ratios or doctor-to ratios, and all treatments in our practice, the very first time a person receives ketamine, are done with the doctor for the full 90-minute period of time. Layered there is then the psychotherapeutic orientation around this. We do things like intention setting. We help folks pair those intentions to music therapy, to aromatherapy if they so choose. We try to make a supportive environment, not because it's going to cause them to have a certain experience. These are not directive in that way, but because by putting the person in a state of mind where they are more likely to be thinking about the therapeutic utility of the content that comes up in these sessions, we feel we can help harness that component of why this is actually helping. And then we spend a lot of time after the infusions holding the space. So in addition to a formal medical and psychological clearance that we do for every patient on every visit, we've tried to set up spaces where patients can actually feel comfortable spending time with us, journaling, enjoying some tea, reflecting on what they're doing. And we operate in New York City, so spending some time before you go back out into that metro area is a nice thing to do. And then lastly, that ecosystem of care is pretty fundamental to what we're seeing, and I'm actually going to show you some outcome differences that we have on that. We do not replace the mental health wheelhouse for a patient who works with us. We add to that wheelhouse. We provide an additional service. Again, patients who work with us have to have a New York licensed provider, psychiatrist, therapist, occasionally a primary care doctor, as those are managing most of depression in the US. And then we each have our role in that care team. Roughly 30 to 40% of the day-to-day of our doctors is spent on care coordination, not the provision of ketamine. It's spent calling and talking to the patient's therapist and psychiatrist to coordinate all of this. There's more there, but it gives you a hint of why we think this is so important. And then for whatever it's worth, we've shared patients. We've treated patients with 3,000 partner providers in the New York City area. So we've worked with a lot of different people in this same type of model. The last bit of kind of core to how we think of this comes out in this orientation to ketamine, not as a silver bullet, not as a treatment that you're forever cured from your depression, but from day zero, from that first phone call as part of a long-term care model. We take a very big difference between what I'm going to mainly talk about for the rest of the presentation, the established relief foundation of care. Does ketamine work for this person? And running that in a way that you can be confident about your outcomes. And then only if that person does positively respond, moving them into trying to maintain that response over time. For the most part, our long-term care is symptom-driven. I personally believe quite strongly that there's not enough consistency between how long people go after their sessions to give an artificial timeline for how often to see them. I'll present some of that data. But there are also patients who really don't like trying to monitor their symptoms over time and choose to pre-schedule, because for that individual, it's a more supportive structure for them. Either way, you have to make people aware that it is expected that they will be coming back, as this will not prevent them from getting depressed in the future. It will help resolve that depressive state when it's happening. For the therapy side, you're actually getting a lecture later from people who actually wrote these papers, so I won't go too deep here, but point is that there is great evidence for the neuroplastic aspects post-ketamine, and with any type of neuroplasticity, that can be harnessed. It is not a passive benefit that will work for everyone. You actually have to do things in the neuroplastic window. You have to engage in therapy. You have to try to change your habits. But when that is done, you can see some really powerful changes. I don't have time today to go into our data on this. We see patients go longer between visits when they go to therapy. We actually see a couple other things in our long-term outcomes where people who take advantage of the neuroplasticity have better long-term outcomes, but it is a component to make sure that you're thinking about as it comes to your long-term care. And then lastly, just a shout out, we are, as you can tell from how I talk, rather data-oriented. We're publishing all of this, so we're hoping to get conversations like these couple of days going where folks contribute to that field of data, where we can actually start saying these things, not with just our strong professional opinions, but with numbers and stats. As you've heard from other lecturers, that is the kind of stuff that will make it more likely to get insurance to cover this, to actually push the field forward from a standards basis. So specific to our Foundation, our initiation series. First off, that starts before the first treatment. Part of our screening is figuring out who we're actually even going to be willing to move forward with as a treatment process. So on intake, there we go. We have a couple of things that are table stakes. The patient has to have a diagnosis of MDD or bipolar. That diagnosis has to be made by somebody that Ember Health does not employ. So an outside provider licensed in New York has to make that diagnosis. And we have to have permission from that individual to work with their care team over time. They sign releases that allow us to communicate. If they're not willing to let us talk to their outside care team, that is okay. We are not able to treat them in our practice accordingly. That said, we treat a lot of patients with a lot of other things. So it is normal for our patients to have other comorbid illnesses. I'll talk about what those are statistically in a minute. It is normal for our patients to be taking other medications for their depression. And it is pretty typical for our patients to be suicidal. I'll talk about that actually specifically in a few slides. Not for today's presentation is the data that we also have on adolescents, on individuals who are pregnant, who are breastfeeding, postpartum, as well as individuals with characterological issues. Those each have very different consent processes, and we actually have a lot of other rules for those patients. They have to have, as example, a pediatric psychiatrist who's working with us, or a peripartum psychiatrist who's working with us. But we have been willing to treat those individuals, and again, we are publishing that data with those patients' consent so that we can try to move the field in a way where this isn't just anecdote, but we're actually seeing what happens when used in these cases. Who we will not treat in the outpatient setting are individuals who have a psychosis or schizophrenia background. There are suggestions in the literature that you can do that safely. Those sessions are much more likely to be difficult and to need additional support. So our stance is that that should be done inpatient or with higher resources than we have in the outpatient setting, and hence they get screened out. And then our physicians are all EM trained. So all 6 of our docs have emergency medicine backgrounds, and yet still, there are a series of things that we will not do in the outpatient context for these folks because we want to make sure that we're operating in an environment where safety can be paramount. General rule of thumb, without going into too much of the weeds on comorbidities, is if you are functioning in your activities of daily living, if you can walk, if you can go for a light jog and not have medical consequence, we're probably going to think it's okay to treat you with ketamine. If you are not able to perform ADLs, we feel that you should have additional resources by your side, particularly if you're going to get this treatment. So, who are we actually working with? This analysis ended up being just shy of 2,000, despite my original title. We used a cutoff at the very beginning of 2019, in that our patients in 2018 had slightly different treatment protocols compared to what you're going to hear for what I'm presenting today. Nevertheless, we see quite a few folks. First, gender or sex assigned at birth specifically, it's the ratios that are pretty typical for mental health, 60% female, 40% male. Age range is very wide, and again, not going to talk about the adolescent data we have today. And we also treat folks who are on the older side of things. The gentleman who was 89 is now 92 because he's still with us. In terms of original diagnosis, 90% of our patients have MDD as that diagnosis, 10% have bipolar. Our average PHQ-9 on intake is a 17. We have quite a few patients who are 27 out of 27. And on the suicidal concept, 50% of our patients have a suicidal thought in the 14 days prior to starting care with us. If you go to subsection 9 of the PHQ, half of our patients have some sort of suicidal ideation when they first start working with us. Comorbidities are common. Most of our patients have a concomitant anxiety disorder. Quite a few of our patients, about a third, have trauma backgrounds. We do treat patients who have a substance use issue, either alcohol or another substance. Those patients also have a lot of different care protocols around them in terms of working with a professional who is additionally trained in substance use issues. But we see those patients relatively commonly, and we see a lot of success with those individuals. Note, we're treating their depression. We're not trying to say that this is the right treatment for their substance use issue. We're addressing their depressive disorder, even if they have a substance use issue, in addition to that original diagnosis. In terms of how long they've been dealing with depression or what types of depression, most would meet the criteria for treatment resistant, whatever criteria you want to use there. So if it's 2 meds in lifetime, that's 9 out of 10 of our patients. If you have an artificial window of the last 5 years, that's 80% of our patients still meet that treatment-resistant criteria. And then we have a decent number of folks who've gone through TMS or electroconvulsive therapy previously. Demographic-wise, we see that most of our patients have a therapist or somebody providing psychotherapy. Now, most in this case is about 70%. It's not 100%. So 1 out of 3 of our patients don't have a therapy provider as part of their care team. They have somebody doing medication management in that case. They have to have one of the two. No one has none. Nevertheless, 1 out of 3 of our patients don't have additional psychotherapy outside of our practice, and we don't do psychotherapy. Inversely, on the prescription side of things, most of our patients have a prescribing provider. You can see the breakdowns here again. In terms of what we do clinically for that initiation series, so our structure is to do 4 treatment sessions in a 14-day window, so 2 a week for 2 weeks. Before the very first treatment session, there's an in-office orientation. They sit down with a physician for a half hour, no ketamine involved. That can sometimes be thought of as a preparation session. Again, though, not structured as a psychotherapy preparation, but structured as expectation setting, making sure we've addressed concerns, talked about anything else that hadn't already been brought up. And then the orange bars are when we do measurement-based care. So we are big believers in trying to track everything we do. We get a PHQ-9 on that initial intake screening call. That's the average of 17. We then do a PHQ-9 on the day of the first treatment session. On the 4th treatment session, 3 days, 9 days, and 14 days after. I'll be the first to point out that a 2-week retrospective taken at that frequency is a little bit strange, that we're asking people, how have you felt in the last 2 weeks, yet it's overlapping quite considerably each time. Nevertheless, it's a situation where more data is helpful, and you'll see the outcomes there. Note, when I say 4 infusions over 2 weeks, it's technically 4 treatments in 14 days, and we give patients the discretion about how to schedule those within the 14-day window. So we don't make people do 2 a week, week 1, 2 a week, week 2. They do need at least 1 calendar day between visits. So as you heard from the prior presentation, Monday, Wednesday, Friday, Monday is the fastest that a patient can schedule this. They could also do something like Monday, Friday, Monday, Friday, and still qualify for this. Why? So again, this is why we originally made these decisions. Some of the supporting evidence I put up here for reference sake, but there are studies out there showing that 2 treatments a week for 2 weeks versus 3 treatments a week for 2 weeks done in a randomized way showed that those 2 things were the same from an outcome basis. That is not the same thing as saying 2 treatments a week for 3 weeks is better than or different than 2 treatments a week for 2 weeks. So you got to be conscious about how many weeks you're doing in addition to the number of treatments, but nevertheless, some data suggesting that 4 was sufficient. McIntyre's group actually put out some great data showing that you should really finish all 4 sessions, that the likelihood of treatment response went up for each and every one of those visits. And this gets into a point that I wanted to make for the field where one of the reasons I suspect that there's so much debate around how many to do at the beginning is due to the fact that there's a group of folks who take a few days to respond after visit 4. If you believe McIntyre's data and ours, 25% of people who will find response to this, who will do better from these 4 treatments, don't feel better on the day of visit 4. They feel better 7 to 10 days later with no additional sessions. And so if you're providing a 5th and a 6th session in that 3rd week, it's very easy to conflate that their response is from that treatment as opposed to understanding that it could be a delay from what you originally did. The only real way to answer this is a trial. However, I think it starts to explain why we see such strong opinions on people doing it in these different courses, in that you might actually be seeing simply a delayed response from the first 4 visits, and it might not be necessary to do visits 5 and 6. Dosing, also big conversation. Our stance for what we did was to do a weight-based dosing range. Every patient starts at 0.5 milligrams per kilogram. We will have a ceiling, which we will not go above, of 1.0 mg per kg. And then how we go between 0.5 and 1.0 is based on 2 things. One, are they feeling better? So we don't adjust dose based on experience in the office. We adjust dose based on symptom response between visits. If they start feeling better, stay on the lower end of the ranges. If they have not yet reported improvements, we start to go up session to session. And then the second part of this is we go up more or less each visit based on how long it's been since the prior visit. Given that there's about a 72-hour average time before people feel better, if 2 visits are scheduled within 72 hours, we only go up a little bit because we do not know if it's just that they need more time to have response or if it wasn't a high enough dose. This looks like a big decision tree in the end. It's a little less complicated than it sounds when I say it out loud. But be aware that everything we're doing lands in that window. Part of the reason we do the adjustments in the 2 weeks is some of this data about ketamine exposure on more regularly than once a week likely leads to some degree of either tachyphylaxis or tolerance, depending on how you want to think about it. So you need more of the same medication to have the same neurologic effect. Whether that's because you're clearing it faster, because your receptors are less sensitive, big discussion there. But nevertheless, it does appear to be true from some of the early data, hence the thinking for why we structured it in this way. And then I have a big note there. Any provider doing IV infusions, worth checking your equipment. We found that 15% of our drug was being trapped in the tubing that we gave. And so if you have a pump and you're running a line and you haven't buffered for the loss factor in that tubing, you're probably underdosing your patients compared to what you think you're giving them. And so we factor in a tubing loss buffer for all of our doses. So what's mixed in the bags is about 15% higher than what we say the patient is getting because we calculated all of that. And it's an exercise worth doing for your equipment to make sure that you're giving them what you think you're giving them. This is the evidence. This is on the slides you can see from the app. So I won't spend too much time here, but these are the things that led to that original thinking. Last point to make in terms of what likely has an impact on our data, we have some relatively strict prescription guidance for folks where, again, we don't do the prescriptions. We won't take over writing prescriptions for our patients. In fact, we chose that our medical malpractice was not going to cover any prescriptions. So our docs are licensed and have malpractice coverage of the in-office administration of ketamine, but they do not have any liability exposure if they were to write a prescription for this patient for anything, Prozac or ketamine at all. That was a very conscious choice we made because we wanted to, again, keep good guardrails about what we feel comfortable doing, what's the highest level of our licensure that we felt comfortable working at, as opposed to our partner providers. That said, care coordination. So we do an enormous amount of partner education with our psychiatrist partners or our prescribing partners around these 4 classes of meds. Without getting too deep on each one, the general framework we advocate for is the lowest tolerable dose. Benzos as an example, 40% of our patients are on benzos when they meet us. Goes to 20% after treatment. We see a really remarkable change in benzodiazepine use as a result of this. But that's done as a conscious decision making. They try to take the lowest amount they can without triggering withdrawal or side effects. That also goes into our in-office treatments, and we have one of the publications we're putting out about the adverse events of our patients over time. One of the big factors for that is that our benzo use in office is tiny. We give a benzo to help keep the patient calm about 1 in every 1,500 visits. So we administer a benzodiazepine less often than 1 in 1,500 sessions. Most of the time we support a person, it's psychological de-escalation. It's the individual occasionally pausing the pump. But we're really big advocates that if the early data on benzodiazepines interfering with ketamine's antidepressant effect is correct, we really want to be doing everything we can to not negate the treatment that we just gave them. So what do we see? First off, we started noticing very early that there's a big difference in how you even talk about treatment success. And that distinction is between the magnitude, how well the person feels as a result of this treatment process, versus how long that improvement lasts for. And so when you start even reporting on treatment outcomes for this, you actually have to keep these 2 things distinct. When it comes to magnitude, we used what CMS uses, which is change in the PHQ-9. We used remission as less than 5. The star is because it's not equal to 5, it is less than 5. You actually will see, if you look at the literature, there's variance in how people report on remission. Some studies include 5 in that number, even though CMS asks not to. Treatment response, was that a pre-treatment score improved by at least 50%, but didn't achieve remission. So these are mutually exclusive categories. And then subjective is its own hour-long conversation. If a patient didn't hit the numeric criteria, say their PHQ went from 20 to 11, technically they wouldn't meet treatment response by the numbers. I don't think that's right, personally. And so we allow those patients to continue in our care if and only if the patient reports qualitative changes and their partner provider reports that they're doing better. Those two things have to line up for patients in the subjective treatment response to be able to continue in our care in the long term. These were our outcomes. This number, 1,800, is slightly lower than the 1,900 because about 5% of our patients are transfers of care to us from other providers where we do not make them re-go through this if they're doing well. So de novo patients, patients who hadn't received ketamine before, these are the outcomes that we saw. Essentially, 40% of our patients are achieving remission. An additional 31% of our patients are achieving treatment response, PHQ better than by 50%. 16% of our patients are in that subjective category where they don't meet numeric criteria, but they and a partner provider are saying that they're doing better. Depending on how you run the analysis, either 8.5% of our patients fail, or if you include everybody who dropped out, who didn't finish all 4 sessions as a treatment failure, then it'd be about 15% where treatments don't fail. So even with all of this, about 1 in 5 patients do not see treatment success. That is expected. No treatment is going to be perfect. If it got much better than that, we'd also start to question if we were measuring this correctly. And then I told I'd show some data on the difference between patients, whether they had that therapist or not. So we found, statistically, that patients who had a therapist as part of their initial care team were more likely to achieve remission. They were less likely to have frank treatment failure, and they were much less likely to drop out of the treatment process. Now again, this is a therapist in addition to our work. This is not doing therapy during the sessions. But nevertheless, these were measurable and, I'd argue, meaningful differences between the two groups, where you can increase the likelihood that this is going to help somebody by about 10% if they engage with a therapist. You'll also note that I didn't say therapist trained in anything. This is just having a therapist. We did not try to say you have to have X type of practice, X licensure, X additional training, and beyond just having that New York State license for psychotherapy. And so this is a lot of different providers practicing in a lot of different ways, and yet we can still see a meaningful difference for having that person as part of the care team. I was supposed to make it each part pop out as we go along. So then we get into the duration of improvement. So it is fantastic to see roughly 4 out of 5 patients doing better, but how long do they do better for? What's it actually take to keep this and maintain this over time? We measured the duration of that improvement in this analysis as the time between the last treatment session of the foundation, so visit 4, and then the time to the first treatment return. Treatment return is when patients have symptoms recur. So we provide longitudinal, ongoing follow-up with our patients. Even after those initial visits, they stay in our care plan. They stay on our care teams. They get, at a minimum, every 2 weeks a PHQ-9 from us, and often it's a lot more than that we're interacting with them. So even though we're not providing in-office treatments, we're still following them over very long periods of time until they tell us, I don't want to do this anymore. That also means that we can then choose when to see them back based on some semi-objective numbers, where if a person's feeling well, my stance is that it's hard to argue that more ketamine is going to be doing anything. If they're not in a depressive state or starting to get a depressive state, it's unclear to me what I'd be giving them ketamine for. So we wait until there's some degree of either objective, the numbers changed, or the patient tells us. Because remember, the PHQ-9 is a 2-week retrospective. Folks are going to notice when their depression comes back before that score changes. And if they can report to you clear signs of depressive return, you don't have to wait for the score to get worse. You're actually probably behind the curve if you're waiting for the number to change too much. But nevertheless, you can use it as a way of ensuring closed-loop communication over time. So because of that long-term follow-up, what we do is we advise folks to come in based on their symptoms. If a client feels comfortable proceeding in this manner, we'll continue to communicate with them over time. And then we wanted to learn, and what this analysis is going to show is how long did they go? How well did they feel for what period of time? Because that is its own kind of naturalistic study of how long we think this can be lasting. The things that we wanted to get answers for is, okay, most patients are at this frequency. People who come in a lot more often on the 10% left side of the curve are at this number, and people at the longer term are at that number. And this is what we found, where essentially patients do come back. At some point in time, it is likely that they will return for treatment because those symptoms are recurring. About 6% of patients who are in remission do better than a year. So there is a chance that a patient who achieved remission as their initial outcome goes more than 365 days, but 6% is not very likely. So that's, again, going back to we expect them and we coach them that there will be some degree of symptom return. When you do, this is a Kaplan-Meier looking at incidence of when that happened, when the first visit occurred. It's censored based on if they were still in our care and yet hadn't received a treatment by the time we ran this analysis. Meaning if they've been with us for 3 weeks and haven't yet had enough time to come back, this is a statistical way of handling that. So on average, for people who are in remission, they're going about 6.5 weeks before they need to return for their first visit. On average, for folks who were in treatment as that initial improvement, they went about 4.5 weeks. For folks who are coming in a lot more often, roughly 10% of our patients come back every 2 weeks. So 1 out of 10 of the people we treat we'll see twice a month to maintain these improvements. On the other end, we see a very wide range. Folks in remission go almost 6 months. On the 10% of folks who are in remission, go 6 months or more to the first time they have to come back to us. Whereas if a patient had treatment, so a 50% improvement, but not less than 5, they average closer to 3-4 months on that right side of the curve. I will note that we don't have a single patient of the basically 1,200 in this analysis. There was not a single patient in treatment who went more than a year. So the stats would suggest it's about a 1% likelihood, but in terms of real patients, we haven't seen anybody whose response wasn't remission who went more than a year before the first return visit. Putting those numbers into a slightly more easy to interpret way, so 10% of folks come back every 2 weeks, even though the magnitude of response could have been as high as a full remission of their depression. On average, it's 6 weeks between treatment sessions. And then for 10% of our patients, they go that 6+ months between visits. Most of our patients are in remission, so that skews that number to be slightly longer. It really does matter how much the initial magnitude was when giving advice to the person we're talking to. So things I'm hoping you take away from this. 1, there's a real difference between the magnitude of effect and the duration by which those benefits last. Our language around this is that it's not ketamine in their body causing them to feel better for weeks and months. You all know ketamine's got about a 45-minute half-life given intravenously. So when they feel better for long stretches of time, they're not in that depressed state, and then it's going to happen that they get stressed again, they have new trauma, they have new negative things pushing at them. They can go longer between visits if they do supportive behavior, if they do things that help minimize the consequences of stress. But how long you go between sessions is not a function of this drug. It's a function of how likely is your depression to be re-triggered. We have whole papers that we're hoping to publish on that for the long-term data beyond just the first return to visit, but for patients that we've now been looking at for 6 years. Approximately 84% of individuals dealing with clinical depression benefit from this particular structure of care. So 4 visits with all of the stuff you heard me talk about. We do see meaningful benefit from that wraparound psychotherapy. It's about 10% of the treatment outcome can be attributed to that therapeutic relationship. And yet we also don't do that psychotherapy ourselves during the session. We provide psychological support. We do a lot of that, but we don't try to actually go into frank therapy in that room. And then, as you heard, 6 weeks between those sessions. So with that, I'm sure there are questions. I'm going to pause and take them, but thank you for your time.
So we're gonna get, if you ask questions without the mic, so if you can submit them in here. Oh. Okay, because when on the recording, if you guys don't have a mic, we're not going to be able to get any of the audio. So here, I'm going to give this to you, and then I'll go through the ones in the app. Thanks.
3 quick questions. So vital signs. How are you obtaining vital signs and how frequently? So again, not to interrupt the patient, are you using anything to suppress urination? Number 3, well, I've got a couple. Additional IV supplements that you really believe in.
Sure.
And number 4, coaching instead of actual psychotherapy. Have you used coaches, and if not, why? Just again, sorry.
I'll try to answer quickly. Medication, vital sign monitoring, we have whole protocols around. All patients get vital signs their first visit, no matter what their medical background is. SpO2, heart rate, blood pressure. It's Q10-minute blood pressures, so it does interrupt things slightly. After the first visit, it depends on how well they responded to treatment 1. If they have no medical comorbidities, we are comfortable with visual monitoring by a clinician at all times. They can always escalate to the monitor. The monitors are in the room. The clinician sees something, they'll put them on the monitor, but we don't require it for all of them if they have no comorbidities. If they have comorbidities, that changes. It's comorbidity specific. This is one of the things our doctors recommend for each and every visit is what level of monitoring do we feel like, based on their history, based on their prior exposures to ketamine, does this person need as a guardrail for this? And we've protocolized all of that. We don't do supplements. We're IV ketamine and saline, that's it. So that makes it pretty easy. Apologies, you asked. Again, for us, because of the medical adverse event concerns, all of our staff are clinicians, nurses or doctors. And then the additional psychotherapeutic training they get is in-house. It's not magic. It's normal stuff about managing difficult conversations, psychological de-escalation, stuff most of the staff already are familiar with from their other work. We then layer in things like intention setting. Again, it's not magic. It's trying to do things in a way that support the person without saying this is the right way to do it. Other questions?
Here, and that, if you would mind later, maybe going in
Sure.
and answering some of them. Thanks. Do you allow community therapist partners to be on site for infusion sessions?
We don't. Goes back to the medical monitoring and safety concerns. Likely you could run a bunch of those sessions and nothing would happen. And then every now and then something really bad would happen and the person in the room might be in the way. And that's our rationale for why we make sure that it's only the clinician. These are also very small spaces for us. These are about 10 by 10 rooms. There's really not a ton of other space for another physical person to be in during that. And so we again ensure those boundary lines between what we do in office and the monitoring we provide, and then the supportive care they might get after the session.
What is the protocol for your clinic if the patient were to end their relationship with their outside mental health professional?
We stop care. We try to help bridge them to other providers. We give them names, we give them referrals. But if they're refusing to collaborate with anybody else, then we also have to stop for them.
What is your opinion on only 50% of your patients from psychiatrists? I was expecting more indications from these professionals.
That probably has nothing to do with us, it's just the state of mental health in the US. Half of depression is managed by primary care doctors. And so a lot of the folks who work with us, One Medical, for example, is the biggest group that refers to us. They don't tend to employ psychiatrists directly. So I suspect it has more to do with the current mental health landscape than it is anything that we're doing. And again, if they didn't have a psychiatrist, they do need a different professional working with them. So somebody else licensed in mental health in New York, usually a therapist or a psychologist.
Is it a requirement for your patients to currently be on an antidepressant or meet criteria for treatment-resistant depression?
Not a requirement. Most do meet that definition, 90%, depending on how you cut it. But no, we've changed in the last 7 years. We used to be more strict on requiring treatment-resistant as a category. My belief was the data would suggest treating earlier in depression is better. And so we started allowing patients who hadn't yet formally met that criteria to start, again, as long as their mental health professional was the one doing the advocacy for the treatment.
Do you do any routine labs at regular intervals on patients that continue to have maintenance infusions?
We do not.
Can you share your dosage calculation?
I can try to find a way to publish that. It will be in the publication we're putting out, so it's not going to be secret. I can try to find a way to get it out before then.
Thank you for publishing this data. It's very important. Have you tried 6 treatments over 3 weeks versus 4 to see if that delays relapse?
Our stance with the limited data that's been published was that it was hard to argue for 6, particularly given the challenge that most patients have on accessing care being finances. We're in New York City, we charge $550 a treatment session. We try to price that to be reasonable in the New York area, but it's still a lot of money. And you'd have to argue that the treatment outcomes would need to bump up by more than a 30% difference to make that change in price make sense. So if you put on that systems hat, if you're going to do 2 more sessions and charge another $1,000 on top of the $2,000, you would need your outcomes to improve by at least 30% to make that a reasonable thing to do at scale. Hard to go up above 85%. So it could be that things become better at some basis. Could be that patients go longer at some basis. Personally, I'm going to wait for the data on that before I change.
And then last question that I'll ask here is, on the long-term maintenance patients, are you seeing any side effects?
That'll be a whole paper. We've done 26,000 sessions, treatment sessions. We see suicides. We've seen 2 over our patient populations, 2,000 people treated. We've seen 1 overdose, unclear if it was intentional or not, and 1 gentleman died from complications of his MS. So probably not related to what we're doing. We see roughly 1 in 10% of our patients report a psychologically challenging session, but we only intervene on closer to 1 in 50 sessions. So we actually wait for patients to signal that they would like some support during that time before we act on that. And then the vast majority of our intervention is psychological de-escalation, talking to them with their permission, doing therapeutic touch, holding their hand. If I remember correctly, it's roughly 1 in 800 sessions we pause the pump. Most of those times the pump resumes after we calm the person down. And then benzos was the number I gave before. It was about 1 in 1,600 sessions we need a benzo. And I think over the 7 years we've been doing this, we've had 6 times that we've sent a patient to the emergency department from our practice for a medical concern. So they happen, and we're going to start seeing more and more of them. If we didn't have a doctor or a nurse in the room, we'd probably have done a lot more of sending people to higher levels of care. But it's not the expected thing, it's what you have to build around to make sure people stay safe.
Excellent, thank you so much. We're gonna give a moment to get, thank you so much for your wonderful presentation. Everyone, we're going to just give it a minute to get chairs up there and we'll introduce our panel.